So let's see what are the commonly used scores in the scenario of shoulder instability. We see in so many patients who have multiple episodes of shoulder dislocation. Predominantly they are anterior dislocation. So only operating them is not enough. We have to score them so that we know that are we going on the right track or the patients are getting better or not. So there are so many scores that we use in our common practice in the OPDs that are evaluated both before surgery and after surgery, and we compare them to see how good the patients are doing. Let's see what's the first score in our armamentarium is. The first score is called the ROVE score. It's a 0 to 100 score based tooling system which is used to assess shoulder outcomes, especially after surgery, especially in the case of instability scenarios, in which we are evaluating the stability for 50 points, we evaluate function for 30 points, and give 20 points to the range of motion. In total, it's a 100 score system in which best outcome is the 100 points and the worst outcome possible is the 0 points. We have various categories like if the patient gets less than 15 points, it is regarded as poor outcome. 51 to 74 is fair outcome. 75 to 89 is good outcome, and 90 to 100 is an excellent outcome. Again, the 50 points is for stability, 30 is for function, and 20 is for motion. You can see all the points here. It is a clinical based scenario. We don't use radiographs, MRIs, or X-rays in this scoring system, so it is easily done in the OPD scenario. Let's see, the other one is Western Ontario Shoulder Instability Index, or the WOSI index. We are using this to quantify the subjective disability in patients due to instability. We are assessing the treatment outcomes after surgery or even after conservative management of a first timer shoulder dislocation. It is a very highly sensitive test and is responsive to clinical change very easily. The index has 21 questions and each of them have four domains. The first part is the VAS score and the second part is a functional outcome. In the functional outcome we have 21 questions. The 0% is the inverse score in the sense that 0% is the best outcome measure and 100% is the worst outcome measure. Let's see the third score. The third score is Oxford Shoulder Instability Index, or OSIS. It is again a patient reported outcome measures in which we record the outcome in the terms of symptoms as well as shoulder disability caused due to shoulder instability. It represents the patient's perspective more than the clinical assessment. So it is patient's self-evaluation form that can be filled and does not require a detailed instruction from the clinician. We can email the patient or send the printout to the patient and they can fill them on their own in their own language. The questionnaire has 12 questions and it has 5 response in the terms of 0, 1, 2, 3, 4. So the maximum possible score is 48 and the least possible score is 0. In 0 is the worst possible outcome and 48 points is for the normal shoulder or no residual instability symptoms. So obviously higher score means better results. For gradation point of view, more than 40 is considered good to excellent outcomes. 30 to 40 is moderate symptoms and less than 30 suggests that patient still has a significant instability and disability. We use the score both preoperatively as well as postoperatively so that we can see how much improvement we have in the patients that occurred in our OPD. It is a simple test and validates and reliable our success very easily. Let's see the other score. This is the most important score that we have. This is called as shoulder instability score. It is not a functional outcome measures. It represents or it guides us the risk of subsequent dislocation at the time of dislocation. We have so many parameters such as age. If the age of the patient is less than 20, patient gets 2 score. If the patient is in competitive sports or contact sports, then the patient gets higher marks. If there is hyperlaxity in terms of higher beaten score, we get 1 marks. If there is no hyperlaxity, patient gets 0 marks. If the Hill-Sachs lesion is available on AP view, mind you, it is not a CT based investigation, it is true AP view X-ray investigation. If the Hill-Sachs lesion is visible on AP view, we get 2 marks, and the glenoid loss is visible again only on AP view. We don't require MRI or CT scan if the glenoid bone loss is such that it is visible on the X-ray, the Hill sachs and the glenoid. We give them 2 points. So again, if the total score is more than 6, then patient has a very high risk of recurrent dislocation, and some patients may opt for lethargic surgery rather than Bankart if the score is higher and the risk of recurrence is very high even after Bankart repair. Let's see the next score we have. The next score we have is ASES, or the American Shoulder and Elbow Surgeon Score. It assesses the pain and the functional outcome, and again the scores is from 0 to 100. As I said, there is gradation. Not only scores is gradation. 90 to 100 is excellent, and less than 50 is poor. In this, the VAS score is important, and then they have questionnaires. In total, there are 10 questionnaires which are graded from 0 to 3. 0 means inability to do so, and 3 is no difficulty at all. So again, higher score means patient has retained the normal finding. One of the very important score we have is the Walsh score, or the Walsh Duplass score. This assists both pain, stability, the sports activity as well as mobility. Again, the scores ranges from 0 to 100, in which the pain has 25 marks, no pain means 25 marks, occasional pain means 20 marks, and severe pain means 0 marks. The second concept is the stability index. No instability, patient says there is no subjective instability, 25 marks. If the patient has recurrent dislocation, 0 points. The third facet is the mobility. If there is no restriction of motion, the range of motion is totally free, patient gets 25 marks. Severe limitation, 0 marks. Then again, return to sports. If patient has returned to his prior activity which he had before the time of dislocation, if he has returned to the same level of activity, he'll get 25 marks. Gradation with a slightly reduced, recreational only. And if patient is unable to return to the original activity or the sports that the patient was involved in, that he gets 0 marks. So again, higher score, normal. So they have so many scores. Which score to use? There is always a confusion which score to use in which scenario. We use most of the scores, but Rove score is mostly focused on stability. Shoulder instability score is the only score that can tell us the chances of recurrence after dislocation. The Western Ontario score tells us the quality of life index, and the OSIS scores is mostly a patient reported score, so we don't need a clinical clinician to be present at the time of recording the scores. This is how the advantages of each of the score I have mentioned, and the ASES mentioned measures all the pain and the function. So which score to use? All the scores are useful. Try to use as much score as possible. For research and quality of life, WOSI score is the best. For clinical outcome, ROVE score is the best. Well, we used OSIS, WOSI, RO, NASS, all of them. You can suit yourself which score is the best for you. Thank you very much.